Hi, this is Bobby Kimbrough, Weapon Off the Cuff. Another day of excitement here. We have Dr. Priest here from Novant. Is that correct?
That's correct.
Yeah, I'm excited to have you today. Excited to learn about who you are, what you do. I know a little bit about you, what I read, and what they provided for me. But as always, welcome to Off the Cuffs. We're glad to have you.
Great. Thanks for having me.
You know, one of the things we always like to do when we have guests on the show is, while we know who they are, tell us a little bit about yourself. You and I were talking off camera, and we talked about you were a military brat. Well, you were a military son. How about that? I don't think you were a brat.
Oh, I was a brat. That's fine to call me
Yeah,
brat.
yeah.
That's what we refer to ourselves as military brats too.
Wow.
Yeah.
So tell us a little bit about you.
Yeah. So I grew up in a Marine Corps household. My father was a Harrier pilot.
Wow.
Remember jump jet Harriers that are still around.
Thank him for
not
his
too much
services.
longer.
Yeah.
He was career Marine, 26 years.
Wow.
He got out and got another degree in education and taught high school chemistry for a couple of decades.
Wow.
So I grew up in that household. We moved around about every 4 or 5 years, and then decided to gravitate toward medicine and went to Wake Forest University for undergrad. And then I was a medical student there, and then an internal medicine resident there. And then I went to Vanderbilt in Nashville, Tennessee to do infectious diseases fellowship.
Impressive.
So
Yeah.
That's
So
my background.
So we conclude that you know what you're talking about.
Well,
Well,
I think so. It's you learn a lot along the way, you know.
Appreciate that.
I had a real wise resident tell me one time, he was referring to medicine. Look, Priest, you don't have to be that smart to do this job. You just got to care and keep up with the details.
Like that.
And I took that to heart. You don't have to be that smart to do this. You just got to really care and keep up with the details.
So tell me, you know, you and I were talking about the Delta variant. You and I were joking about the mask. I was saying, you know, I remember not having the mask on a while ago. And we were talking about, here we are in the Delta variant. When people say that, explain to because a lot of people are still not in the know, or they don't really know. There's a lot of myths, rumors floating around about it. I'll give you one that was so crazy to me. I was in a barbershop, and we was having a conversation about the vaccine. And they were saying that the vaccine is a liquid chip that they're shooting in your arm to keep up with you. And I was like, wow.
Yeah.
I hadn't heard that one.
Right. Yeah, so, you know, obviously we've been dealing with this for 19 months, and this thing has gone around the world. And this Delta variant is a variation on what the first version of the COVID virus was as it went around. And this one's super contagious. And so what we've learned is you basically got two options with this thing. Eventually, every one of us will have antibodies in our body against COVID. Like, since we're humans, we all have antibodies against the common cold. As we've grown up, we all got a cold, we got antibodies. This is no different. Every one of us will have antibodies to it. You have to choose whether you want to get antibodies by getting it itself or by having a vaccine, because there's no dodging this. Unless you're moving to a deserted island where you're going to live there by yourself forever, there's no dodging getting this. So, hence the vaccine.
So when you say getting this, you saying getting it like catching COVID, or getting it through the vaccine?
I mean, catching COVID.
Catching COVID.
Right. So because there's basically 100% chance you're gonna have antibodies, you either have to decide it's from catching it, or you're gonna get a vaccine that's going to give you the antibodies so you don't get it. Now, the vaccines aren't perfect, but they certainly don't do things like put a chip in you. The ones that we use right now, the Pfizer and Moderna vaccines primarily, they're very interesting technology. It's been around actually longer than people realize. And it's a kind of technology we're going to be using for the prevention of cancer and treatment of cancer going forward. There's a lot of exciting things that are going to happen with it. Traditionally, when we give you a vaccine, remember the old vaccines, it would take some germ and they would weaken it and they'd give it to you.
Right.
And then you might have a reaction like a smallpox vaccine or one of those MMRs. And then they said, the technology moved along. So the next kind of vaccine was one, they said, we're going to take the germ and then we're going to squeeze some antigen, some proteins out of it, because you don't even need the whole germ. You just needed part of it. And they gave you a shot, like our flu shots are like that now.
Right.
What this one does, it says, we don't even need to do that. We're going to take this really fragile instruction manual called mRNA, and we're going to give you that. And for about 2 days in your arm, the cells there take that little instruction manual. It's super fragile. And it makes a protein, tells your cells how to make the protein that your immune system needs to see to protect you. And then the instruction manual, that mRNA, is so fragile, it disappears, just breaks up into nothing. So it's not a chip. It doesn't stay in your body. It doesn't alter your DNA. It's actually remarkable. It's just unfortunate those kind of rumors float around.
So is it safe to assume you've had the vaccine?
Absolutely. And I'm anxious to have them tell me when I can get a third dose.
Really?
Yeah. Because if I need it, I'm going to get it. But right now, the vaccines are holding up very well. Like if you look at the numbers in our hospital right now, about 90% of the people we admit to the hospital are unvaccinated. As of this morning, about 98% of the people we have with COVID in our ICUs unvaccinated, and about 98% of people on ventilators with COVID unvaccinated.
So you said 98% of the people that are on ventilators are unvaccinated.
That's right. That's right. And the people who get vaccine and end up in the hospital anyway are typically much older, sometimes in their late 70s. They often were vaccinated early on in the pandemic, and they often have other health problems. So if you're otherwise pretty healthy, you get a vaccine, you might get a mild case of COVID, you might get the sniffles, you're not going to end up in the hospital, and you're not going to end up on a ventilator.
Wow. That's pretty interesting. 98% of the people that are on the ventilators are not vaccinated.
That's right.
That's pretty impressive. So when you look across the numbers and you look at things that are data-driven, is there a certain group of the population that is refusing or has not been vaccinated?
Yeah, absolutely. And we've dealt with that from the beginning. And sometimes there are very valid reasons that people are hesitant, right? So maybe there's some historical health inequities, in particular communities of color who've had health inequities for many decades or had bad experiences with the healthcare system. Obviously reasonable for those folks to say, I need to think twice about it. I need to get some more information about this before I decide whether I'm going to do this or not. So very understandable. But then you have others that are maybe more conservative. Maybe some folks that are have a particular religious bent or particular political leaning. Those folks are hesitant too. So it's not just one group that's hesitant. It can cut across.
So let me ask you this. Are you seeing that the COVID, the virus, is killing more people in a particular ethnic group than it is in others? Or would you say it's pretty much equally distributed across the various?
I would say that it is more inequitable in communities of color. We've seen a higher percentage of severe cases and deaths in communities of color. And often that is related to sometimes chronic health problems in those communities.
Well, I read that, but you being the expert, I wanted you to expound on that because, being a person of color, being a black man, I hear a lot of conversations. I myself, I have been vaccinated. My boys as well. My two youngest kids. And so I hear a lot of conversations as to, can we trust that? Should we do that? What's the benefits of it? Barbershop conversations are some amazing conversations. I love going to the barbershop. I learn everything from folk putting a chip in you to not being able to work their arm anymore, to people doing demonstrations of what they think is in the COVID vaccine. It's just amazing to me. And so every time I hear the conversation, I love talking intelligently about it because I think the more we explain what is really happening, because people ask this question all the time, well, how did they come up with a cure so quick?
Yeah. Yeah. So the issue with that is that it's not as quick as they think. So the mRNA vaccines have been around, that technology has been around for a number of years.
Okay.
The reason this could happen so quickly, several things came into play. Number one was there was unlimited money, right? So governments and companies suddenly had a common enemy that they could put this technology to use against, and they poured billions of dollars into it. Traditionally, if I'm a scientist at a university and I want to develop a vaccine, no one's handing me billions of dollars to do it. I have to raise money and I have to get grants and very, very long process just to get the money to develop that vaccine. That was not an issue here whatsoever. Two was, thousands of volunteers came forward and said, we're willing to go into these clinical trials now. So it didn't take much time to recruit volunteers into doing it. And three is mRNA by its nature is a lot easier to produce and make. Remember old flu shots that we used to use? We grew those in eggs in a factory. That's a very labor intensive and time intensive. mRNA vaccines you can make much more quickly. So no steps were skipped in the safety process of the vaccine. It just felt faster because unlimited money, lots of volunteers, a technology that's easier to put out. And so we feel very confident in the safety profile and how things have gone. And I get it. Like people say, this isn't the usual thing that happens, but a lot of things worked in our favor.
Wow. So what do you do? What's a typical day like you at Novant?
Yeah. Depends on the day, right? So I still see patients. So I have a clinic.
So you're the vice president?
I'm a senior vice president, safety and quality and epidemiology. right?
Epidemiology. Okay.
So I do a couple of half days a week. I'm in a clinic and I see all patients with infectious diseases. So HIV, hepatitis C, COVID, unusual fevers, travel health, unusual infections, maybe not common in the United States. We do those things. And then as the Chief Safety, Quality, and Epidemiology Officer, I'm focused on projects that are designed to improve the safety and quality of the care we provide.
So you know what else I've heard in the barbershop, and I felt, just when you were saying that, is there a cure for AIDS?
No, not yet, but I think mRNA technology may play a role in that going forward.
You think so?
Absolutely. And the
Is
thing
there a cure for cancer?
Lots of them. And a lot of cancers now are almost chronic conditions that are managed over long periods of time.
Mm-hmm.
Think about HIV. One of the reasons I went into infectious disease medicine was I loved HIV and I loved those patients. And we have 9 or 10 now 1 pill a day options, and those people live a normal lifespan. So I think the public doesn't always hear that or understand it. But early on in the HIV pandemic, people didn't do well, right? We all know the stories of people dying of AIDS.
Right.
Now, more than 50% of my patients are over the age of 50. So it used to be, well, we don't have to worry about your cholesterol or that kind of stuff because, you're not going to live long enough. Well, now it's like, you're going to live to be 85 years old. We better manage your cholesterol and your heart and your liver and all those things.
Wow.
So people do so well. It's actually, for me, very rewarding. Their visits are simple. They take 1 pill a day and they go about their business. And there's nothing they can't do in this day and age. And I think these mRNA technologies may be part of the cure that comes for HIV.
So you think we'll have a cure one day?
We will one day. The sooner the better. I kind of dream it'll happen during my career. And I can say I practiced in the HIV era. Like when I started, there was no cure and a few pills. And then at the very end, it was a cure. And I'll set my stethoscope down and go home.
That's amazing. That's amazing. I've always wanted to ask that question. So I got another question for you. So when it comes to health, right? And so a lot of people say, well, all healthcare is not equal. In other words, all things are not equal and equitable. So from where you sit, would you say that healthcare is equal and equitable throughout the community, in the Black and brown community? Would you say that the affluent, the rich have better access to it? Or is there a different like I've heard people say this barbershop conversation that the medicine that the rich are prescribed is totally different than if I go, they want to sell me a generic version. People have asked the question, what's the difference? And I've always thought this myself. I have this conversation sometimes before, and I say, well, if I prescribe the medicine, do I want the generic brand or do I want the brand?
Right.
And in my opinion, now, I'm not a doctor, right? Not yet, not a doctor of medicine, but my thing is that if there is no difference, then why is it called a generic?
Right.
And why does one cost different?
Yeah. So a lot to unpack there. So the first question is, it is not equitable, and we know that. And so healthcare systems like ours at Novant Health have developed diversity inclusion programs with a real focus on understanding this. And in the part I do for Novant around safety and quality, we do a lot of data, dashboards, and we've committed that we don't create a single data tool that doesn't have a diversity inclusion lens on it, right? You may say, hey, as an organization, we're meeting some quality metric, but have you looked at it from every angle? Have you looked at it based on race and ethnicity and age and zip code and sexual orientation and all of those things? And so we have to put those lenses on there because you may think you're doing well in getting cancer screening to this group, but when you really break it down, you realize this group's lagging behind. One example in our organization we focus on is mammogram. Right. So when we went to look and see where was the inequitable mammograms in our system, actually the group that was number one in getting their mammogram were women of color. But Asian women were behind. So we had to put our focus on those kind of women. So that's a very important lens. So the first thing is it is not equitable, and we were striving to make it equitable. Some of it is also around insurance, right?
I appreciate you being a truth teller. I have a lot of respect for you.
Well,
Thank you.
Insurance is an issue too, right? Because in this country, your insurance is tied to your job.
True.
Right? So if you're unemployed, you don't have insurance. And you know what Cobra costs, right? It's a ridiculous amount of money. So that makes things inequitable. And it goes down to the generic versus, name brand drugs. In most instances, the generic is perfectly fine.
So I got a question for you then.
Yeah.
So if a family member of yours, right, cousin, whatever, was going to get a prescription, what would you tell them? They want a generic or they want the brand.
I think generic's perfectly fine. Now, it depends on what problem you're treating, right? There's a lot of
would you
medicines.
take a generic, or would you
Absolutely.
Really?
In fact, I do all the time. Yeah.
I don't. I say, give me the brand.
Yeah. Now, occasionally there's slight differences.
See that? Now
but
you
for a lot of
scared me
things,
again. See, you saying slight differences.
well,
See?
I mean, in terms of you could take a name brand and have an allergic reaction to it, you might not to the generic. And it's not necessarily in the medicine itself; it's the thing that gets packaged in. So there are people who say to me,
so they cutting corners in the generic brand.
well, not necessarily. they may say, hey, we think it's better, right? But things that have been around a long time, there's no reason you can't take a generic. I take generic medication.
Really?
Yeah. Oh,
But
absolutely.
if it's serious, no, you don't.
Oh, I do. I take generic. Yeah.
Really?
Absolutely.
Okay, I believe you. All right. So going forward, so I got to ask of you, right? You said that it's not equal, it's not equitable, right? And you explained a lot of things that Novant is doing to try to bridge that gap. What can we do in the community?
You can put pressure on organizations like mine. When you say, hey, I live in this zip code and I don't see the kind of healthcare services in this zip code, is that zip
Well,
code
so you know
across
what?
town?
So I've had a couple people from your office, right? And I hadn't got the invitation yet, that was going to invite me to the board meeting, right?
Yeah.
Where we was going to have a conversation about some of the issues that you're talking about in our community, Black and brown communities. I know somebody saying, what are you talking about? He don't, he live in wherever he lives, right? What I'm talking about in our community, because all of this is our community, regardless of where you live, it's our community. So I would love to be a part of that conversation as to how do we do that. I hear this conversation and I have to say it to you, is that right now, we get on the highway right now and we head which way? You know where I'm going, right?
Yeah.
If we head which way? West, right?
That's right.
If we head west, we're going to catch a hospital every half a mile, pretty much, right? And people say to me all the time, well, Kimbrough, you have this platform, you have people coming and going and people talking, right? But you all are talking, but we don't see any results. And so there are certain areas that I can't force somebody's hand and I can talk about it and hope that somebody hears me, because everything that you have said is true. Everything that you have said, I've researched and read myself. And one of the things that I love and I hope that we bridge those gaps, because healthcare and that equality and that equitable distribution of healthcare, we should spread the love.
Absolutely. And I think the COVID crisis has helped bring that into focus, right? So we, during the pandemic said, where do we need to put COVID testing that it's not there?
Right.
Where do we need to put COVID vaccination where it's not there? Let's set that up and put it there. And a lot of times we hit the exact right mark. And then occasionally someone say, you missed this spot. And we said, you're right. We've got to get to that spot as well. The state of North Carolina has actually done a pretty good job through all of this. And I can tell you at Novant, because of the diversity inclusion team we have, Jesse Curitin, Tanya Blackman, Cherie Gregory, physicians and leaders.
I know Dr. Gregory.
Yeah.
Yeah.
Well, so when all this came about with COVID and they started talking about, I wasn't an expert, but I could speak some of the language. They had taught me enough to say, hey, you need to be looking out for these things, and so we can get ahead of it. But absolutely, you ought to be part of the conversation in this community about ensuring equitable care.
So who do I need to speak to? Who do I need to ask? Can I have an invitation to come and sit down at the table, plead my case, and move some of them resources that you all have? Because you guys got a plethora of resources and money, right? You got endless money. What's the word you said?
Well, we are a nonprofit. Endless money is a strong word.
You got endless money, right? You got endless money, endless resources, right? So what I'm saying is, who would I need to talk to have a conversation about bringing some of those resources into the Black and brown?
I will ensure that the right people know about that. I have a lot of street cred right now. When you're the COVID guy,
you got a lot of street cred.
I got a lot of street cred right now.
But that's the thing. We got a lot of street cred, and the people know about it. They're able, but but when are they going to be willing? It's one thing to be able.
They're willing.
They willing?
Oh yeah, and some of this has been started. The question is not a question. I can tell you it's not everywhere it needs to be yet, right? So that's exactly right. We've got, you've talked to Pam Oliver in this setting, right? The president of our medical group. Jamila Speaks, you've talked to her here.
I did.
Carl Armato, you know what he
Well, I
thinks
never
about all
talked
this.
to Carl
We're going to
Armato.
bring Carl in here.
He ain't came yet.
I
heard he was coming.
Here.
Can you look? Can you? Hey, Mr. Armato, we waiting.
Yes, absolutely. And he's committed to that too.
He is, he really?
Absolutely.
You gonna get him to come see me?
Sure.
You gonna come back with him?
I'd love to.
I really would appreciate that, Doc. That would mean a lot to me. It does. You know, I hear the cries of the people, and it makes me cry sometimes. And I'll tell you why. Because being from Winston-Salem is a razor blade. It cuts both ways to me. Because the people know me. They know I'm from them. I'm of them. And so they expect a lot from me. And sometimes so many things are happening that I see they're right when they're crying out for the needs. And I just want to be a voice or a conduit to bring those resources where they need to be, because it is a need. And so when I saw that I was talking with you, I did my own little research, even though I was asking you. I just want to make sure, right? I know you're a guy that is influenced. You have a voice, and I just want us to use our voices to make some things happen, because at the end of the day, we're all in this together. At the end of the day, you know, we're stronger together. That's one of the things that I say constantly around here. We are in this together. We're stronger together. It is proven. When you said something that I learned as an agent with the government, that anytime this country has a common enemy, it has endless resources and endless funding. That is a fact. I've seen that throughout my career, throughout my life, my professional life. And so when you said that, I said, wow, he's right. And COVID was a common enemy to all of us across the economic, social boundaries.
Absolutely.
And so we put all resources, all hands on deck for it. And so I think that if we use that same energy, that same synergy, there's nothing that we couldn't accomplish. Anything that I can do for you, anything that I can do for Novant to bring this to fruition, I welcome that. And I love what you're doing. I appreciate you in the community. When I go back to the barbershop, right, I'm going to have my chest out. I'm going to say, now look, I don't talk to Dr. Oil. I don't talk to Dr. Priest. I don't talk to the two guys who are the experts on infectious disease, right? And they told me there's no chip in it. It is safe, and we need it.
Yep. And I tell you, those are the kind of conversations that move the needle, right?
Yeah.
They can throw Ole up on TV. They can throw me up on TV. They don't know me.
Right.
When I have a conversation with a patient like this, and they come in and say, I ain't getting that thing, and I explain to them, they change their minds by the end of it, almost all of them. So, but that takes time, right? There's thousands and thousands of people you got to talk to, but it's those kind of one-on-one conversations that actually get people to understand, get rid of the. I had a lady come in not too long ago, a few weeks ago. I said, you got your COVID vaccine. She immediately kind of put a wall up, kind of angry. You can see it in her face. You know, I'm not doing that. Well, let's talk about that. What are your concerns? We went line by line. And by the end, that day, she drove over and got her first dose. So people just need that. You got to meet them where they are. You got that one-on-one conversation with someone they trust. They're going to trust you in the barbershop. They trust me in the office. This is a patient I had a relationship with for 10 years. So you trust me. So we just explain the facts. I go, I got it, because there's so much misinformation out there that they got to sort through constantly. They almost throw up their hands and go, I can't figure this out.
So if I invite you to the barbershop and some of these places where Black and brown people gather that are not being vaccinated, will you come and have a conversation?
Absolutely. Absolutely.
Your street creds will increase then.
Well,
listen. You know, it'll move way beyond that circle, man. You'll have it all covered.
That's
then.
good.
Yeah. Well, I want you to know I appreciate you. I enjoyed talking with you. Anything you want to ask, anything you want to say before we go?
There's a lot to balance for all of us, right?
It is.
From COVID to kind of racial injustice, school shootings. And I want to thank you because, I've told you before we got on here that my daughter goes to Mount Tabor.
Thank you. I appreciate that.
And when I saw you and Chief Thompson on the screen after that day, I had this sense of relief, and I thought, they're the right people are there, and that's given us a lot of comfort for me and my family. That. So we're all in this together. I love the fact you talk about Winston-Salem as a community. We got things we got to improve on, but we can get there. And I've told my team, we have to be different after all of this. We can't, when people say, I just wanted to go back to normal, I don't really agree with that. I don't want there to be COVID, but I don't think what we had before was what it needed to be, right? What is
Right.
normal?
What is
I don't
normal,
I don't
right.
want normal to be what it was before all this.
I don't either.
If you're not different because of COVID, if you're not different because of racial injustice, if you're not different, something's wrong.
It's
I'm a
true.
different person on the far side of this. So how can we make it better? And that's what we got to focus on.
I was telling one of my majors, he joked with me all the time, right? He's a happy-go-lucky guy. I love him. He was talking to me about 6-7 months ago. He said, Kimbrough, you've changed, right? And I said, I don't know how you could live every day and not change.
Absolutely.
I don't know how you could go year to year and not change. And I definitely don't know how you can go through these pandemics, social unrest and COVID, and not be changed.
Yeah.
And I say, so I hope you change, because if you haven't, your growth has been stunted.
Yeah.
So,
last summer, we were earlier in the pandemic, right?
Yeah.
Remember, what was the date of the first Black Lives Matter march in Winston? It was in June, I think, right?
Right, something like that, yeah.
So I'm the COVID guy at Novant Health, and I felt very moved to attend that event. My daughter wanted to go, but I was thinking, but what about COVID?
Yeah.
Right? What am I? You was going to say the COVID guys out there,
Yeah.
and But I said, if everybody's masked and we're outside, I
Yeah.
thought it was a reasonably safe thing to do. And I'd never gone to a demonstration like that before.
Really?
So
Wow.
we go out, my daughter, my wife, and I go out there, right? And I'm gonna wear a hat, sunglasses.
Yeah.
I'm gonna stay over to the side
Yeah.
because I'm gonna be like, oh, there's a COVID guy out here,
Yeah.
giving people COVID, right? So I'm wearing a mask. The young men who organized that, remarkable job keeping it organized and moving it along and having all the, it was just amazing experience. But I thought, no one will know I'm here, but I want to show my support, because who would recognize me in shorts and a t-shirt, right? So I'm
Right.
walking up 4th Street and we're chanting, right?
Yeah.
And I see there's an African-American woman to my left.
Yeah.
I can just kind of see out of the corner of my eye.
Yeah.
She says, Dr. Priest. And I look at her and I was like, how did you recognize me? And it was one of my patients. And I had that little debate before I went. Should I do this with COVID and everything else? Not because I didn't want to support it, but with
Right.
COVID. And when I saw her, she said, I'd recognize you anywhere. You're my favorite doctor.
Wow.
That moved me. And I said, I knew I'd done the right thing. We had 2 public health disasters happening at the same time, racial injustice
That's
and
right.
COVID colliding. And here I was colliding with both things right at the same time. And and she and I have this, I've seen her since then in the office, and she knows I had her back that day. And that's when I felt like we gotta do things differently on the far side of this.
Wow. Sir, I want you to know, I really have enjoyed this. I appreciate you. I see it in your eyes, and I feel the passion that you have for doing what you say you want to do and bringing people together and changing the narrative. That means a lot to me. Before we go, I just want you to know that we enjoyed having you here. As always, I love my community. I love my city. I love my country. More important, I love you for what you do, because you make us better. And remember, we're better together, stronger, and much wiser. Until we talk again, have a great rest of your week. Thank you.